So how many of you have had or expect to have worried breastfeeding mothers book in to see you, only to find, after assessment, there are no clinical concerns? What advice would you give in this situation? Hi, my name is Aleshia Dearlove, and I'm here to present a 1-hour speech in just 10 minutes about breastfeeding. I work for Counties Manukau DHB for Tini to Order Community Breastfeeding and Nutrition Advice. My qualifications are in health science and integrated human health.
Hey everyone, my name is Katie Turnwald. I'm fresh out of university and I studied a Bachelor of Public and Environmental Health, and I work alongside Aleshia at Rito Order as well.
With regard to the scenario here, it's well worth knowing the most common reasons families stop breastfeeding before they wanted to, even when things clinically appear okay, is sore nipples or perceived low supply. Take note, usually sore nipples can be helped or totally fixed by ensuring the mother is positioning the baby correctly and the baby is deeply latched onto not just the nipple, but the areola as well. Briefly, what this looks like is the baby should be held so close to the mother that there is no space between the mother and the baby, so that baby's tummy is on the mummy, tummy to mummy. Remember that with regards to latch, we could be here all day, but to give you one takeaway message, baby should be breastfeeding, so on the breast, not nipple feeding. Nipple feeding causes sore nipples. All right, with the perceived low supply, some mums worry their supply is low even when they have an ample milk supply. This is usually due to a misunderstanding about what is normal. Maybe they didn't realise that frequent night waking to feed is normal, or baby will have growth spurts at around 3, 6 and 12 weeks. So instead, the mum thinks hunger means inadequate milk supply, and so she gives up before she wanted to. This is what I call the problem of the perceived problem, and it is very, very real. Mothers may not know about physiological baby behaviour, and a mother should not be expected to blindly guess her way through infant feeding in a blur of stress and sleep deprivation. We can empower our mothers with knowledge of what is normal. Well-trained advocacy work illustrates the need to not only, this is a strength, of well-trained advocacy work, and it illustrates the need to not only inform our mothers that there are breastfeeding support services out there, but to create the opportunity for all mothers to access breastfeeding support services, even when things are going really well. For complex medical needs, what we see is that often, by the time a mum and baby are referred to a lactation consultant, the problem has become more complicated the longer the problem is left. It's like the ambulance at the bottom of the cliff situation. So refer early for better outcomes. All right, as health professionals, we are part of a mother's village of support. And your advice and words are so influential as to whether or not a woman reaches her breastfeeding goals. Your words hold so much power. So I want to do a little exercise with all of you. Turn to the person next to you. If you're by yourself, you might have to play this on your own. And if you don't know each other already, just say hello, break the ice. Now for this exercise, I want you to tell the person next to you what your understanding is of the following two statements. It's coming. Okay. All right. Bigger breasts mean more milk. What do you think? I'll give you 5 more seconds. All right, this is a common misconception. The last GP talk I presented, about a quarter of the room thought that this was true. It is absolutely not true. Breasts are made up of fat cells and mammary glands. A woman might have a lot of fat cells in her breasts, making them appear larger, but the mammary glands are what produce and eject milk. Mammary glands are stimulated to develop during pregnancy by an increase in hormones like estrogen and prolactin. This is why breasts appear to grow larger in pregnancy. However, do not be fooled that a bigger cup size means more milk in those cups. Now, one more statement. It's coming. Can a mum breastfeed if she needs antibiotics? I'll give you 10 seconds to talk to the person next to you. 5 seconds. All right, so the answer is that she can keep breastfeeding on antibiotics. This is also a really common misconception, and unfortunately what we see with the work that we do in our community is that all too often mums give up breastfeeding because of a round of antibiotics. Now, it is safe to continue. Medication needs to be looked at on a case-by-case basis for compatibility with risks versus benefits weighed up. There are various databases to look at for medications, such as SSRIs, narcotics, etc. Do consult with an LC if you're unsure. There are people that do this for a job, so please find your local LC and do ask them. So lactation consultant is LC. The advice to pump and dump is, or to not breastfeed for a duration without even looking up the medication is not best practice, which segues nicely into so what's the big deal about giving a bottle or asking a mum not to breastfeed for a few days? Well, this sabotages breastfeeding. Often, a mum has worked really hard to establish and maintain their breastfeeding supply. It can be absolutely devastating for a mum to be incorrectly advised to stop breastfeeding due to medication. When we start giving bottles, the blood, sweat, tears and education that the mother has possibly literally gone through can be impaired. The mechanism of lactation is that it works by a homeostatic negative feedback loop, with suckling on the nipple being the stimulus. The more suckling that occurs, the more signals are sent through to the pituitary gland to make more milk. When there is no stimulus, the brain decides, I don't really need that supply, and so shuts it down. There is a bit more to this, but that's a general overview. The take-home message is that when a mum is advised to give a bottle to not feed from the breast, her milk supply will reduce. This has a snowball effect where the less the mum latches the baby to the breast, the less milk she makes, and so she gives more formula. The more formula is given, the less supply she has, and so she gives more formula. You can see where this is going. If she wants to breastfeed, the advice to give formula is not helpful at all. Sometimes it's clinically indicated, but a lactation consultant can help to advise around those things. Find support, refer on. More information can be found here on this page. And now I will pass you on to Kate, who will dazzle you with the benefits of breastfeeding, referrals for tongue tie and services available.
So Te Rito Ora is a free Counties Manukau community-based health service that provides information to women in whānau around healthy feeding for their infants and toddlers aged 0 to 2 years. Our focus is on supporting and encouraging breastfeeding and the timely introduction of first foods. We are a community-based service, so once women are back home, we go out to their homes and visit them. We've previously had the opportunity for GPs to come along to our community home visits. So if that is something that any of you are interested, please do not hesitate to contact us. So why breastfeeding? There are many benefits to breastfeeding as breastfeeding helps lay the foundations of a healthy baby. Being able to breastfeed contributes positively to the infant and maternal health, as well as the social well-being of baby, mother, whānau, and community. There are important components in breast milk that help with the physiological growth. Babies who are breastfed have a lower risk of respiratory infections, type 1 and 2 diabetes, obesity, and SUDI. Mothers that are able to breastfeed have a lower risk of breast, uterine, ovarian cancer, hypertension, as well as postnatal depression. Being able to breastfeed means that the family is saving a cost of buying infant formula. We provide many services to mums and whānau in Counties Manukau. Our most significant services, however, are postnatal home visits and antenatal home visits. We do home visits during pregnancy for antenatal education. We try to book these between 28 to 32 weeks. Some topics we go through at our home visits are the benefits of breastfeeding for mum and baby, skin to skin, and position and latch. Postnatal visits are after mum comes home with baby. We go in and see how breastfeeding is going and if there are any issues. Tongue ties are a hot topic with mothers, and many worry that their baby has one. So what to do if a tongue tie is suspected? A very small percentage of babies have a tongue tie. Only around 5 to 8% of babies truly have a tongue tie, and that interferes with breastfeeding. When a tongue tie is suspected, first ensure mum is positioning the baby correctly and that the baby is achieving a deep latch. Most damage with breastfeeding is caused by incorrect position and latch rather than a tongue tie. Tongue ties are diagnosed by either a midwife or a lactation consultant with the correct credentials. Assessment is based on not just the appearance, but the function of a tongue. If a mum reports her baby has a tongue tie, it can be wise to ask, who advised the mum of the tongue tie? Sometimes mums are advised that their baby has a tongue tie as a throwaway comment rather than being correctly diagnosed, which can lead to the mother giving up breastfeeding altogether. And then who advised the tongue tie? Is feeding going well, but someone thought that they saw something in the baby's mouth, or do they have a bias and will profit from an unnecessary tongue tie procedure?
So the correct pathway to refer to the lactation consultant in your area for assessment first. At Counties Manukau, this is Botany, Papakura or Pukekohe maternity units where there are midwives with the correct credentials, or Te Tiriti Ora where our lactation consultants can assess baby appropriately. It is often a slower pathway to refer elsewhere first. For example, when a mother is referred to an SLT, as part of the screening for tongue ties, the referral is not accepted unless an LC performs a HATLIF assessment first. So the importance of GPs referring mamas to our service is because the Ministry of Health recommends exclusive breastfeeding for 6 months, which means that the baby doesn't need food or water for the first 6 months of life. Breast milk will meet all of baby's nutritional needs. We know that breastfeeding rates start to drop at 3, 6 and 12 weeks, and at around these times babies have growth spurts, and so they start to cluster feed because they need more fuel to grow bigger, which is often misconceived as a low supply when it's not. This is totally normal behaviour, however some mums start doubting themselves. All right, so this is just information if you are in Counties Manukau, otherwise refer to the previous slide as well. So we are from Te Rito Order, Community Breastfeeding Nutrition Advice. I will definitely be hanging around for morning tea, so please come and have a chat to me if you want any more information. Thank you.